Record to the cloud. We haven't finished rectum here, so let's begin with the rectum. Okay, so rectum and the anal canal. So first of all, a little bit of the anatomy, right? So anal canal is considered just the last part. It's only about 4 centimeters, okay, so it's not that big. And here we actually have like skin, okay? So even though it is protruding a bit inwards, this area is still considered to be skin. So it is stratified squamous keratinized epithelium, right? And then there is another portion of the anal canal, which is also protruding this way, but here it is like mucosa, okay? So it's the part which is technically could not be considered anal canal embryologically, but yet it does, okay? So in a way, the true anal canal is only this part where the skin is present. But in anatomy, this entire area would be considered anal canal, including the mucosa, right? So this area right here, which has the non-keratinized epithelium right here, right? Rectum is that part which is going to be kind of opening into the anal canal. Histologically, rectum and mucosal anal canal are indistinguishable, that they're the same, okay? So they look exactly the same. It's impossible to say that this is rectum and this is anal canal, for example. Okay, so next thing that you need to remember is going to be that there is a line, okay, that you have to understand. If this is the skin and this is mucosa, you can actually see the area where the two have fused together. And this is right here, this is known as the pectinate line, okay? So this part right here, this is the pectinate line. Short Zoli does not call it pectinate, he calls it dentate line. Why? Because in actual anatomy, in the practice, when you open the anal canal, you will see that it has this teeth-like appearance, okay? So it actually looks like this. So that's why he calls it dentate line. Embryologically, this is skin, so it is ectoderm. This is mucosa, so it is endoderm. So pectinate or dentate line is like a fusion point of the ectoderm and endoderm. Okay, so it's like a fusion point. You can see where the two germ layers have fused together. Now, if you look at the mucosal area of the anal canal, which we have discussed is pretty much indistinguishable from the rectum, there is one anatomical difference. So histologically, they look the same, but anatomically, there is a difference. These protrusions, they are called anal columns, okay? So they are protrusions of the mucosa, okay? So these are anal columns. Between the anal columns, we have some kind of depressions, like downings, and they are called anal sinuses. So these structures are present anatomically in your mucosal anal canal, but they are not present anatomically in your rectum, right? The names of the anal canal, so as you can understand, there are 3 zones right now. So there is the skin zone, there is the mucosal zone, and then there is the transitional zone. These names are in the book, but in the lectures, they always give you different ones. So you have to, when you have the class, just pay attention to how do they name the zones here, okay? So because these zones are named like this in the book, and when I was a student, but as I noticed, they changed it. For example, I remember that transitional zone is called hemorrhoidal. Okay, so according to the new lectures, like last year, they called it hemorrhoidal zone. Squamous, they called it cutaneous zone. Colorectal, I think they called it intestinal or rectal zone, I don't remember, okay? I remember definitely that the second, which is in the book anal transition zone, in the lectures, they would call it hemorrhoidal. The squamous, this is the cutaneous, and the colorectal, I don't remember how they call it. So we have said that this is your anal canal right here, right? So that's the area. So you can say that it has 3 zones, right? So this is the colorectal area, or whatever name they will give you in your lectures or in your like classes itself. Here, epithelium is indistinguishable from the rest of your intestines. It looks exactly as you're looking at colon or at your intestines. Okay, so it's completely indistinguishable. It's identical to rectum. It's impossible to see the difference. The second zone is transitional. Here, the epithelium more or less starting to change. So it starts to already become stratified squamous. So soon it's going to be keratinized, right? Why do they call it hemorrhoidal zone? Because in the wall, in this area, you can see that there's some kind of veins here. And these veins are called hemorrhoidal veins. And they are the reason for hemorrhoids, right? So if the pressure increases in your rectum, right? For example, you sit for too long, I don't know, you don't poop regularly, so the pressure here increases. As it increases, this pressure is it's being exerted on the walls of your anal canal. So the veins, they start to bulge into the lumen, right? So they start to bulge into the lumen because the pressure is so high. And then by some miracle you poop, right? But one problem is as you're pooping, you're cutting these veins, the veins which are bulging into the lumen, they are being cut by the poop. So you start to bleed, right? So one of the symptoms of hemorrhoids is that after you poop, when you wipe with the paper, you see bright red color because it's not digested. If the color is black, then your bleeding is not here, it is somewhere in your stomach, in your esophagus, because that blood has been digested. So the blood has to be bright red. And then you see, that's what I'm talking about. You see, they call it pectinate, but Short-Zoli, he calls it dentate line because you can see that these are like tooth projections, right? So that's the area where the how do you call it? That's the area where the endoderm and ectoderm are kind of meeting, right? And then there's the last part here, which is the skin, basically. So here you'll see stratified squamous keratinized epithelium. Sometimes even hair follicles could be visible here as well, because this is your skin. There are going to be 2 sphincters present. We have the internal anal sphincter, and we have the external anal sphincter. Internal anal sphincter is a smooth muscle. It's just your super thick inner circular layer, right? So you remember muscularis externa, it has 2 layers, inner circular, outer longitudinal. So you're gonna see that this layer right here is extra thick, so it comes out as your anal sphincter, the internal anal sphincter. External anal sphincter is not smooth muscle. This is skeletal muscle. This is visceral striated muscle. You are in full control of it, right? So we are learning as children to hold on until you reach the bathroom, basically, okay? So you don't just poop yourself. But of course, if you have some kind of damage to your spinal cord, like you were in the accident, depending on the level where the damage was, one of the first things that you lose is the control of this muscle right here, right? So then you'll just be pooping yourself like a baby. Okay, there's some kind of glands. We kind of talked about them. The apocrine glands, as you remember, right? So they are located in your weird areas like axilla, nipple, areolar region, and then the anal canal. So here it is working as a sex attractant because you know that animals, for example, dogs or cats, before they have the sexual intercourse, they sniff the area. Okay, so they notice is it nice or is it not nice? Okay, so luckily we don't do this. So our apocrine glands are not for that reason whatsoever. So it's not for the sex attractant whatsoever. In animals, yes, but in us, no. So we talked about the hemorrhoids, right? That there is elevated pressure of some sort that is responsible for your veins just bulging. And the sphincters, we also talked about it. So here's your anal canal. I can kind of divide it for you into 3 zones already. as a histologist, your first job is to look at the epithelium. So you can see that there is one epithelium here, and then there's a bit different epithelium here, and then there is completely different epithelium here. So you can see how there are three different types of epithelium. That means that there are three different areas in your anal canal, right? So this one right here, even with this magnification, you can see that the top layer is kind of dark. It has like a dark line, so it has to be keratinized. So if this is keratinized, that means that this is skin. So this area right here, this is your cutaneous, the most lower part of the anal canal, right? So this is the skin. If this is the skin, that means that on the opposite end right here, we have our colorectal zone, right? So colorectal area. We can see even with this magnification that there are some kind of protrusions. There are some kind of like protrusions of the mucosa. So these are the villi, right? These are the intestinal villi that we can see here. And then here it's very weird epithelium. It's like transitioning. So here it is stratified squamous non-keratinized, because you can see that there is no dark layer on the top, right? There is no keratin. And then suddenly you can see that it becomes darker. Okay, so it's already transitioned, it's already becoming stratified squamous keratinized epithelium. Here you can see a very, very thick muscle. Okay, so this is your inner circular layer, which is extra thick. And we have said it last class that if it is extra thick, then it has to be like a sphincter, right? So it's like a sphincter. So all of this area, this is your structure right here, this is your internal anal sphincter. Okay, so this entire structure, this is internal anal sphincter. And then somewhere where the skin is, you can see there's a little bit of the skeletal muscle here present. This is going to be your external anal sphincter, right? So here it is the external anal sphincter. Okay, so that's what we talked about. So here we have, this is the internal anal sphincter, the huge, huge thickening of the inner circular layer, right? So which zone is this? Somebody tell me, based on the epithelium.
Colorectal zone?
It's going to be colorectal, right? So this is the colorectal zone, because you can see, how would you call these protrusions?
Intestinal villi.
Intestinal villi. Okay, so these protrusions, which are visible right here, they are called intestinal villi. If you magnify to them, you will see that there are lots and lots of these cells. Which cells are these?
Goblet cells.
Goblet cells. And you remember from our last class, we discussed that generally, if you take a look at your intestines, like starting from duodenum until you reach the anal canal, right? You will notice that the amount of the goblet cells increases, right? The closer you approach the anal canal, the more goblet cells you will see. And we can clearly see it here, right? So basically, your entire epithelium here just simply consists of goblet cells. They're the only cells which you can see here. Of course, occasional simple columnar cells here with microvilli at the top, so enterocytes are visible here as well, but still majority of the cells here are your simple, are your goblet cells, sorry. And you remember what was the reason, right? Somebody remembers? Why do we have more goblet cells as we approach rectum?
Like lubricate for easier to...
Sorry?
For better lubrication?
For lubrication, yes, yes, yes. So for lubrication, because your rectum and your large intestine, they have to be kind of passing this solid poop, and in order to establish a much easier passage, mucus is needed. So the purpose of these goblet cells is for lubrication. They'll make this mucus. This mucus will kind of line the surface, and the poop will be much easier to pass, right? Lamina propria is still here, nothing has changed, so your gullet or whatever. And notice that there are lots of veins. Okay, so these are veins, the anal veins, and they're superficial. They're just right under your epithelium. Okay, so they're quite superficial. Look how superficial they're here. Okay, so in your transitional or hemorrhoidal zone. So they're becoming even more superficial, right? So there's so many of them and they're just approaching your epithelium. So of course, if something happens, look, like for example here, that's a vein, look how superficial. That's also little tiny venules here, look how superficial. If your pressure increases just a bit, that's it. They will be bulging into the lumen like this. Okay, so these little tiny veins will be protruding into your lumen. Yes. So these are hemorrhoidal veins, right? So they are potential hemorrhoidal veins. For now, you just call them anal veins, but they could be hemorrhoidal if they protrude, right? And it's very important to remember that these kind of hemorrhoids are called internal hemorrhoids. Okay, so because they're in the transitional zone, they are internal hemorrhoids. So they don't hurt, they just bleed a lot. So it doesn't hurt to poop, it's just, it bleeds a lot. But if you find these veins like here, do you see these veins? And epithelium is already changing, right? So it's already becoming stratified keratinized, so it's already towards the skin. And you know that skin has lots and lots of nerves, right? So these hemorrhoids will be called external hemorrhoids and they will hurt. So if you poop and it hurts, it's definitely external hemorrhoids, and it bleeds, and it's definitely external hemorrhoids. So the major difference between internal and external, I guess it's the location. So if they are under your non-keratinized epithelium, the amount of nerves here is very limited. So they wouldn't hurt, right? So the area here wouldn't hurt, it would just bleed a lot. But if you are under keratinized epithelium with a bunch of nerves, then they will bleed and they will hurt, and you will call it external hemorrhoids. So here we have our skin area. So it is definitely stratified squamous keratinized epithelium, right? So here we have our submucosa in a way. This area is your internal anal sphincter, and this part right here is the external anal sphincter, which is your visceral striated muscle, right? These structures here are ducts. Okay, so these two, they are ducts. They are ducts of your apocrine sweat glands, okay, because that's where they're located. They're going to be somewhere here. Okay, so we're looking, take a look where we are, right? So we're in the external anal sphincter, because you have to ask yourselves, from this magnification, they look the same. The anal sphincter, which is internal, and the external, they look the same from this magnification. So how do I definitely know that this is actually skeletal muscle, that it's not smooth muscle, it's skeletal muscle? Of course, you need to magnify. And when you magnify, you will see that there are bundles of skeletal muscle fibers, and the nuclei, there are so many of them, and they're in the periphery, right? So that's going to be your kind of proof that this is your skeletal muscle. Okay, so GI part is finished. Now we go for the extramural glands. So this is going to be your gallbladder, pancreas, and liver. Okay, so first gallbladder. Gallbladder is a pear-shaped distensible sac. Its job is to simply concentrate and store bile. So don't forget that gallbladder does not produce bile, it simply stores it and concentrates it. Who is making bile? Your liver. That's why the gallbladder is connected to the liver, right? It's right there, right next to the liver. The volume of potential amount of the bile is about 50 milliliters in humans, right? Have you done gallbladder and liver in anatomy?
Not yet.
No?
No, not yet.
Not yet. Okay, so liver has hepatic ducts. And these hepatic ducts kind of lead outside of the liver, and they become common bile duct. Common bile duct is connected to the cystic duct. Cystic duct is the duct of the gallbladder. So basically you have like left and right hepatic ducts. They come from the liver, they carry bile. Then there is the common bile duct. And what is joining the common bile duct is the cystic duct, which comes from the gallbladder. Okay, so you're going to see that sometimes the bile is not going directly to the common bile duct, it's just going through the cystic duct to the gallbladder, accumulates there. And then some hormones and enteroendocrine cells, they will make some hormones and they will ask your gallbladder to release the bile. Okay, so release it. So don't just store it, put it into the common bile duct. Gallbladder has a bunch of deep mucosal folds. Okay, so its mucosa is very, very much folded. The epithelium there is simple columnar epithelium, and you will see some mucous cells or goblet cells they're present as well. The epithelial cells, the columnar epithelial cells that we have here, they exhibit a bunch of underdeveloped microvilli. Okay, so there are microvilli there, but they're not doing the job which they should. So nothing is being absorbed here. Even though microvilli are present, because they're underdeveloped, you're not absorbing anything. Apical junctions are present there, so they are kind of forming a barrier. So the contents of the bile could not diffuse across the epithelium, could not go to the blood vessel of the gallbladder. There's a bunch of mitochondria there, and there's lots and lots of lateral plications. Plications are just like folds. Okay, so your epithelial cells, they don't only have like microvilli on their surface, they also have lateral plications like that as well. Okay, so there's some kind of protrusions on the lateral wall of the cell as well. Can we see any of these things? Of course not. Okay, so this is a light microscope, so I can only see like a cell which looks more or less columnar and like a nucleus at the bottom. That's all I can see. It's more like a theory. There are no lymphatic vessels in the lamina propria, but it has lots and lots of fenestrated capillaries for some reason. Okay, so for some reason there are fenestrated capillaries. And there's some mucus secreting glands, because again, bile could be acidic, it could be alkaline, it depends on what do you eat, so you need protection from this bile, so that's where the mucin secreting glands come in. The wall of the gallbladder lacks muscularis mucosa and submucosa. So both of these layers are completely absent in the gallbladder. So here the mucosa simply consists of epithelium and lamina propria, and it is attached directly to the muscularis externa. Okay, so remember this, they always test you on this. There is no muscularis mucosa, there is no submucosa. And muscularis externa of the gallbladder is very interesting because it does not only have the smooth muscle cells, it also has a bunch of collagen and elastic fibers, which are kind of intertwined between these smooth muscle cells. Randomly oriented, you cannot see the layers. There's no such a thing as inner circular or outer longitudinal in the gallbladder. Each muscle fiber goes as it wants. And external to the muscularis externa, you can see a bunch of dense connective tissue. So it's not like a layer, it's just there's lots of dense connective tissue, and it possesses some nerve fibers, lymph vessels, I don't know, blood vessels, and etc. The most outer layer of the gallbladder depends, because you remember that if your surface is free, then it is serosa. If it is attaching to another organ, then it is adventitia. Okay, so in this scenario, to what are we attaching specifically? Well, of course, to the liver itself, right? So that part of the gallbladder which is facing the liver, its outermost layer will be adventitia. The one which is free, its outermost layer will be serosa. And now the most important thing, that's all they want from you in terms of gallbladder, there is something which is called Rokitansky-Ashov sinuses. They are diverticula of mucosa. Anybody knows what is diverticulum? How would you describe diverticulum in simple English? Okay, diverticulum is an outgrowth. Okay, that's what it is. For example, your appendix is diverticulum of your colon. It is the outgrowth of your colon. Here, these Rokitansky-Ashov sinuses, even though we say they are diverticula of mucosa, they don't grow outwards. They grow into the mucosa. So they're protruding, would be better said, they are invaginations of mucosa. So the word itself here, diverticulum, is a bit misleading because whenever you like ask yourself what is diverticulum, it means outgrowth. It should come out from the structure. But Rokitansky-Ashov sinuses are not coming out. On the opposite, they're growing into the wall of the gallbladder. They're protruding into the entire thickness of the gallbladder's wall. They are simply a bunch of epithelial cells, so they are diverticular of mucosa. And Rokitansky-Ashov sinuses are pathological. Okay, they're not normal, they're pathological. So this is technically patho. Okay, so technically this is patho, but they do ask you about it always. The problem with Rokitansky-Ashov sinuses is that they are very nice environment for accumulation of bacteria, because think about it, right? So if it is protruding deep into the wall of the gallbladder, it's like a very deep sac, like a deep bucket, which is just waiting to be filled by something. Like what? Bile, bacteria, cholesterol, calcium, okay? These weird things like to accumulate in those places. If it accumulates in those places, it leads to chronic inflammation because it stagnates. It's not being cleared. It just stays within this invagination. And what will that lead to? It will lead to the formation of the gallbladder stones. So to simplify it, the more Rokitansky-Ashov sinuses you have, the more likely you are to suffer from gallbladder stones. We will see them on our slide. Okay, so don't forget that they're not like outgrowth, they're more of an ingrowth. And here is just additional thing that your epithelial cells of the gallbladder, they are capable of transporting both the sodium and chloride and bicarbonate from the cytoplasm into the intracellular compartment, okay? So there you go, here's your wall. So here, this is mucosa, right? And you can see what we have said before, it has lots and lots of folds. So here they are. Okay, so these are the mucosal folds, some kind of protrusions of the mucosa, right, towards the lumen. What is the next layer? What is this layer going to be?
Muscularis.
Muscularis.
Externa.
Sorry?
Muscularis externa.
Muscularis externa, very good. Okay, so this layer is muscularis externa. Don't forget, there is no muscularis mucosa, there is no submucosa. So the next layer is muscularis externa. And then what about this part? How would you call it?
Adventitia.
Adventitia.
Yes, this is adventitia. Okay, so we should have some dense connective tissue with blood vessels here, but as far as I remember, and double check it here on your actual practical as well, double check what do they call this layer, but last year it was adventitia. This entire tissue was called adventitia. So with your professors, double check whatever they say here with the hands out, double check, okay? So we magnify a little bit and this is what we can see, right? So these are the mucosal folds, right? The protrusions of the mucosa into the lumen. And right under it, you can see that already muscularis externa begins. You can see that this is the epithelium, right? And then right under it is the lamina propria. And then you see something like this, that this is definitely mucosal epithelium. It starts here. And then it goes deep into the wall of the gallbladder. It comes out here where adventitia is almost, right? So how would you call this structure? Rokitansky ash of sinus. So this is a very good example of Rokitansky ash of sinus. Try to use your 3D vision. So this mucosa has been protruding downwards, and we can see where it comes out. So definitely it's not straight. If we do like a side view of it, it will look like this, right? It's protruding like this. So if I do a section, I can see the same sinus in two places. This area is here, and this area is here, right? It's like a curved protrusion of mucosa into the wall of the gallbladder. So this is your Rokitansky ash of sinus. This is the one that they give for the self-control test, because this is it's a perfect example of Rokitansky ash of sinus. But if we go back, these ones are the beginnings of Rokitansky ash of sinuses as well. Okay, so these structures, they're within the mucosa. They are the beginnings of Rokitansky ash of sinus. So if we follow them, we cannot see where they come out. So in our section, we cannot see. The only one where we can see is this one. We can see where does the sinus come out. So here it is. It's the same part of the sinus, right? There is something in the adventitia which is called ducts of Luschka. We can see them here. Ducts of Luschka are embryological remnants of embryological bile ducts. Because in embryo, we will learn that gallbladder is like an extension of a bile duct in embryo. So it's just an outgrowth of a bile duct. So we can kind of imagine that here we have those branches of that original bile duct, right? So that original embryological bile duct, it has lots of extensions, and here they are, ducts of Luschka. Does every person have them? No, ours does. Okay, so ours does. We can see that he did have ducts of Luschka. Okay, so again, these are just embryological remnants of original embryological duct, embryological bile duct, which has given rise to all of the bile ducts in the liver and gallbladder. Notice how is the epithelium, because right now it's going to be very important when we do the liver. That's how the bile ducts will look like. How's the epithelium?
Cuboidal.
Simple cuboidal epithelium. So now you should kind of get familiar with this picture, because that's how a bile duct should look like. Okay, so it should have a simple cuboidal epithelium, and there's nothing inside. Okay, so again, you remember we said that your mucosa has lots of mucus producing glands, right? To have some kind of protection from the bile. So here they are. You can see some goblet cells as well, right? Occasional goblet cells, and simple columnar epithelium. Nothing more. Okay, so as I have said, the most important thing is definitely Rokitansky ash of sinus and maybe ducts of Luschka, that they're embryological remnants of embryological bile ducts, right? That's it. Okay, so now we are going to be talking about pancreas. If you look at the anatomical structure, you will see that we have the head, right? We're going to have the neck, we have the body, the body of the pancreas, and this is the tail. Tail is located where the spleen is. So there is like a hilum, the entrance point where blood vessels of the spleen enter. So it's very important, for example, in your anatomy, if you pick the spleen and they'll ask you what is located at the hilum of the spleen, and you'll start going splenic artery, splenic vein, lymphatic vessels, nerves, and tail of the pancreas. Okay, do never forget to mention the tail of the pancreas is also located in the hilum of the spleen. Where's the head of the pancreas? Well, it's kind of pushing your duodenum, right? It's pushing it, and it is the reason why duodenum has a C-shaped appearance, because of the head of the pancreas, because it pushes it to the side in a way. It is an whenever they ask you pancreas, is it exocrine or is it endocrine? You know that it is both, right? So pancreas is both. It is exocrine and it is endocrine as well. But if I have to be perfect, right? I'm usually a student, so I really want to be perfect at this. So how can we say? Pancreas is an exocrine gland with endocrine islands, like an island. Okay, so majority of pancreas is exocrine. More than 90% of pancreas is exocrine, more than 90. So of course it is exocrine with like a little bit of islands of the endocrine tissue as well. There's some kind of ducts here. So return to this part when you're done with anatomy. In histo, they will not talk about it. Okay, that's just anatomical variations of your pancreas. You see that typically there's only one excretory duct because this is an exocrine gland, so it should have excretory duct, right? That's the major pancreatic duct of Wirsung. Okay, where is it? There you go. Major pancreatic duct of Wirsung, that's the name for it, the main excretory duct. But sometimes embryologically, there's some people who have not one, but two excretory ducts. And that accessory one is called accessory pancreatic duct of Santorini. Okay, not everybody has it, but some people do. So they just kind of right next to each other like this. How do you call the area where the pancreatic duct and the common bile duct open into the duodenum, right? As you can see, the two ducts will be fusing together, uniting, and then opening into the duodenum. This area is going to be known as the hepatopancreatic ampulla of Vater or Vater's papilla. Okay, Vater's papilla, that's just the entrance point in the duodenum where the two ducts will open into, right? So the pancreatic and the bile duct. Exocrine portion of the pancreas is going to be making enzymes which are needed for digestion, right? And the endocrine portion of the pancreas is to make hormones like insulin, glucagon, somatostatin, right? So these are going to be the hormones that pancreas can make. We have said that pancreas is an exocrine gland with endocrine islands. How do we call the endocrine islands? We call them islets of Langerhans. Remember Langerhans? Have you seen this word before or no?
You have
Yeah.
cells.
Sorry?
You have cells of Langerhans
Yes, where?
in the skin.
Yes, and what is their job?
Spinosome.
They act as dermal macrophages.
It's the antigen presenting cell of the skin, right? So don't forget that Langerhans cell is the antigen presenting cell in the skin. So same dude. Okay, so same dude that has come up with that cell has come up with the islands of Langerhans. Okay, so these are the endocrine islands. Okay, let's talk about exocrine pancreas. Exocrine pancreas is identical to your parotid salivary gland. Identical. So when you look at them, it looks like you're looking at your parotid gland. You remember, what does parotid gland consist of? There's acinus, right? And then there is the intercalated duct, and then there is the striated duct, right? And then there is the excretory duct. But there is a major differences between the exocrine pancreas and parotid gland. For example, intercalated duct of exocrine pancreas actually begins within the acinus. It doesn't begin outside of it, it begins within. So here, this is your parotid gland. If it was exocrine pancreas, how would you draw it? Just a little bit this way. Okay, it begins within the acinus. If you don't understand my picture, always helps this. This is intercalated duct. My pen is intercalated duct. My hand is the acinus. If it is like this is parotid. If it is like this is exocrine pancreas. in your oral, you can do this, they will be very happy. Okay, so acinus continues as the intercalated duct. This is parotid salivary gland. The intercalated duct begins within the acinus. Okay, so this is your exocrine pancreas. So that's one of the major differences. They're always tested in the oral. So what is the job for the exocrine pancreas? Well, we have already covered it. We have said it makes digestive enzymes. Does it make the active digestive enzymes? No, it makes the precursors. Okay, so it makes the zymogens, it makes the inactive versions for them, right? Now, the duct, the intercalated duct that begins within the acinus, it is going to be lined by some special cells. They are called centroacinar cells. Okay, they are going to be a bit cuboidal in shape. Okay, so cuboidal in shape. So they are called centroacinar cells. So these cells, which are lining the intercalated duct inside of the acinus of the exocrine pancreas, you will call it the centroacinar cells. Everybody remembers what is acinus? That's the functional component of the exocrine pancreas. That's the part which is responsible for making our enzymes in this case, right? Acinar cells will look identical to your parotid cells. So they'll also be a bit triangular in shape. At the base, it's basophilia. At the apex, there is acidophilia because it contains zymogens. So whatever we have talked about in the first self-control test, it's also applicable here. Okay, so you remember, right, that triangular shape cells. Here is the nucleus. Here, a bunch of zymogens. As you remember, zymogens are the inactive enzymes or proteins. Because of the nucleus, how will this area be stained?
Basophilic.
Basophilic, right? Because hematoxylin has a positive charge, nucleus has a negative charge, so they love each other. Now, the apical area, the zymogens, these are inactive proteins, so they have a positive charge. So will hematoxylin like this area? Of course not. So who will like this area?
Yes.
Eosin. So that's why it's going to be a red color at the top and a blue color at the bottom. Speaking of zymogens, which kind of zymogens does your cell, secretory cell of the acinus makes? So some of them are proteolytic enzymes, for example, trypsinogen, chymotrypsinogen, right? Notice we say trypsinogen because it is an enzyme, right? It's an zymogen, sorry, because it is inactive enzyme, right? The active form of trypsinogen will be trypsin, right? Proteolytic exopeptidases, so they're just going to be very similar. They're going to be breaking up your amino acids into even more simple form. Then your sugar, right? So alpha amylase, lipase, nucleolytic enzymes, they digest the nucleic acid. What was activating pepsinogen?
Acidic
Acidic pH.
Acidic pH, very good. Okay, so acidic pH was responsible for converting your pepsinogen to become pepsin. What activates any of these enzymes? Because definitely there is no acid. This is duodenum. It's not acidic environment. It's quite neutral. So what will be activating them? The microvilli of the small intestine enterocytes, they possess this enzyme, which is called enterokinase. And enterokinase will be converting your trypsinogen to trypsin, right? So in your intestines, you have enterocytes, the simple columnar cells. These enterocytes possess microvilli. In these microvilli, there is an enzyme called enterokinase. What does enterokinase do? Simply converts trypsinogen to trypsin. Once you have trypsin, trypsin will catalyze the conversion of all other enzymes. So all other enzymes will need trypsin in order to convert to its active form. Clear?
Yes.
So your job is to first make trypsin, right? So convert trypsinogen to trypsin with the help of your microvilli in the enterocytes, right? Once you have done it, then trypsin will do the rest. It will convert all other enzymes to its active form. Duct system. We have said that pancreas is an exocrine gland. If it is an exocrine gland, so it must have a duct system. So now we have to ask ourselves which kind of ducts are there. The duct system of pancreas, of exocrine pancreas, is very interesting. It's very different. So you definitely do begin with the intercalated duct. And you remember that this intercalated duct begins within the acinus, inside of it, right? And that portion is lined by the centroacinar cells. So again, we have acinus, we have intercalated duct, which begins in the acinus, and this portion is lined by the centroacinar cells. What is the next one typically? It's the striated, right? So intercalated duct should continue as striated duct, but there are no striated ducts in the pancreas. Instead of the striated duct, we have something which is going to be known as the collecting duct. So intercalated duct continues as collecting. And not any collecting, at first intralobular collecting, then interlobular collecting, and only then excretory pancreatic duct. So again, how is the duct system in the salivary gland? Somebody tell me.
You have
Intercalated, striated, excretory.
Striated, excretory. Very good. So from the acinus, we have intercalated, then striated, then excretory. How is the duct system in the pancreas? First,
Intercalated.
intercalated, then
Intralobular collecting duct.
collecting. Intralobular collecting duct. It's a collecting duct inside of the lobule. Then
Interlobular
collecting, then interlobular collecting, and then
excretory pancreatic duct.
excretory. Is it correct to say that collecting duct is an analogy to a striated duct in the salivary system? Yes. Collecting duct is basically striated duct, but the only difference is where they are, because striated ducts are only in the salivary glands, right? But collecting ducts are only in the exocrine pancreas. So that's your duct system. And remember, the primary exocrine, primary excretory pancreatic duct unites with what?
with the
The
bile.
With a bile duct, with a common bile duct, and they are opening into
The duodenum.
duodenum at the area which is called
pancreatic ampulla.
which is called Vater's papilla. Okay, so the area in the duodenum where the two ducts fuse and open into, this is called Vater's papilla. So your pancreas is going to be secreting about 1 liter of fluid. Okay, so that's how much pancreas makes, about 1 liter of fluid. This fluid consists of your enzymes and of your hormones and some additional fluid, right? So this fluid is going to be super rich in sodium and bicarbonate. And which part is responsible for adding sodium bicarbonate? That's your intercalated duct. Okay, so don't forget that water will follow, right? So if I add the sodium to my fluid, so water from tissues will follow. Two hormones are the principal regulators of the exocrine pancreas: secretin and cholecystokinin. Okay, so secretin and cholecystokinin. Both of these hormones are made by the enteroendocrine cells. You remember enteroendocrine cells? The secretin is made by the S cell. S cell is sitting in the duodenum. It is an enteroendocrine cell of duodenum. CCK is made by the I cell. And I cell is also sitting in the duodenum. So S and I Okay, these are the two cells sitting in the duodenum. They are enteroendocrine cells, and they make secretin and CCK. So you can see what are their functions right here. Okay, so what does secretin do and what is CCK, cholecystokinin, is going to be doing. Endocrine pancreas, we have said that it has like islands, so islands of the Langerhans, and they are scattered throughout the organ, the entire pancreas. I know it says here 1 to 2% of the volume, but in the neuro books it says 10%. Okay, so 90% of the pancreas is exocrine, and about 10% are endocrine areas, right? The islets of the Langerhans. Both agree that majority are in the tail. So majority of your endocrine portion is going to be located in the tail. Of course, there are going to be a bunch of fenestrated capillaries because this is an endocrine portion, so it's going to be surrounded by fenestrated capillaries. When do the islets of Langerhans appear? Week 9, 12. So they're the first portion to arise in your pancreas embryologically. So you first make the endocrine portion. Islets of Langerhans consist of 3 types of cells. We have alpha, beta, and delta cells. The 3 different types of cells are indistinguishable in the H and E. So in hematoxylin and eosin, you cannot see the difference between the 3 types of cells. So you need Mallory-Azan staining, which we do not have. Alpha cells, A cells, are enteroendocrine cells. So out of the 3, alpha cells are enteroendocrine cells. So they belong to which family?
GEP.
GEP. They belong to GEP family. So don't forget, in the GI, acute is not acute. It's called gastroenteropancreatic family, right? So we will see alpha cells with silver impregnation. Generally, beta cells are the ones that make insulin, alpha cells make glucagon, and delta cells make somatostatin. Beta cells are located in the center. So in the center of your islet of Langerhans, you will see beta cells. Alpha and delta are located in the periphery. Okay, so the periphery of the islet of Langerhans. You can see that alpha cell can also make CCK. So CCK is not only made by the eye cells of the duodenum, it could also be made by the alpha cells of the islet of Langerhans. So this is why it is an enteroendocrine cell, right? What is the job for these hormones? Insulin, of course, stimulates the uptake of the glucose, right? So the cells start to take up the glucose, start to store it, right? Try to use the available glucose. Glucagon does the opposite of the insulin, right? So it kind of puts the glucose in the different direction. And somatostatin is very important, inhibits both. So if insulin could inhibit glucagon, glucagon could inhibit insulin. Okay, they have opposite functions. Somatostatin inhibits both of them. So it's like a control hormone that regulates both of them. Normal glucose, as you know, should be about 5 millimoles per liter or 7 milligrams per 100 milliliters. Islets have sympathetic and parasympathetic stimulations, and capillaries first perfuse alpha and delta cells and then beta cells. So of course, if this is your islet of Langerhans, in the center we have the beta cells, in the periphery we have the alpha and delta cells. So when the capillary comes in, of course, which cells it is going to perfuse first? Of course, alpha and delta, and only then it's going to perfuse the beta cells in the center. So here is your pancreas. Agree with me that at first it looks like parotid gland without the fat, right? So at first when you look at it, the structure looks like a parotid gland without the fat. But then you magnify and you start to see that these are your acini, right? So these are the acini, the exocrine acini of your pancreas. And then you can see that there is some kind of I don't know, accumulation, like an island of cells. So how would you call this island?
Langerhans.
So this is going to be the island of Langerhans right here. Okay. So again, these structures here, all of them are your serous acini. Okay, so these are the serous acini with a little bit of the intercalated duct. Okay, but I'll show you in a second. And you can see that there are lots and lots of blood vessels between the structures, right? So even between your serous acini, you can see that there are lots of blood available. So it's very bloody organ. So the same idea behind that, here we have here connective tissue, septa, right? And then islet of Langerhans, right? And these are the serous acini. Now, notice this structure right here. You can see that cells are quite normally arranged, right? And then you see a cell in the center. Any guesses what could that be?
The centroacinar cells.
Exactly. So this cell in the center, this is the centroacinar cell. So that's the way it looks. So if I go back, okay, so here I'm going to give you some other options, of course, right? But this is the picture that I wanted to show you. So this is the acinus, this is the intercalated duct, and you can see how it begins within the acinus. So that's how it will look like. You will see just two cells, which are kind of in the center of your acinus, like here, for example, it's only one cell which is in the center of your acinus. So these cells are centroacinar cells. So if we go back, okay, so this is a perfect example for centroacinar cell. These ones, centroacinar cell. These ones, centroacinar cell. So just like an individual cells, which is just sitting in the center of your acinus, they are centroacinar cells, and they are lining the intercalated duct, right? Speaking of intercalated duct, you can see that's how it is. Okay, so here it is a bit bigger, right? It's nothing like we saw in the salivary glands. It's a bit bigger here. And cells here are just your intercalated cells, right? So the cells which are just kind of lining the intercalated duct itself. So again, they're not centroacinar cell, because it is considered to be centroacinar cell only in the acinus, right? So if I again go back to this picture, these are your normal intercalated cells. But these ones are the centroacinar cells, because they are intercalated cells which are in the acinus. Does it make sense?
Mhm.
Okay. So the same situation, you can see just a bunch of acini, nothing interesting. So try to spend some time here and kind of realize that you're not looking at parotid gland, you're looking at the pancreas, right? Okay. It's for you, for you, for you. Okay, so again, the same idea, right? So individual cell just sitting in the acinus, this is definitely centroacinar cell. Then we have silver impregnation. So as soon as you see that this is a silver impregnation, what does that mean for you? Which cell are they trying to show you? The alpha cell. Okay, so the A or the alpha cell, because it is enteroendocrine cell, right? So here is your islet of Langerhans. Which cells are here in the center?
B cells.
B cells, right? So that's the beta or B cells. They make insulin. And then these cells in the periphery, which have a darker appearance, they are
Alpha cells.
alpha cells that make glucagon and CCK and GIP, the gastric inhibitory substance, right? So protein. And then what about these cells in the periphery that are not stained?
The delta cells.
Okay, so that's going to be the delta cells. Okay, so they're in the periphery. So the cells which are non-staining, this is the delta cells. They just make somatostatin. Okay, the same idea, right? So cells in the center are beta, these ones are alpha, these ones in the periphery are delta. Okay, now we come for the part that is very important. So that's going to be your liver. So here are just functions of the liver. What does the liver do? Of course, it's a very important organ. We here could store, distribute nutrients to the rest of the body. That's the area for maintenance of the blood glucose level, because as you remember, liver is the place where gluconeogenesis happens. Okay, so that's the area right here. Here we make majority of the plasma proteins like albumin, right? Lipoproteins, glycoproteins, all the different transporters like haptoglobin, it's the transporter for the iron, right? So transferrin, the same, hemopexin, the same for the iron. We make prothrombin and fibrinogen here. One of them is for clotting, one of them is not for clotting, and we'll make some other proteins here as well. Don't forget that liver also converts several vitamins to its active form. So for example, vitamin A, D, and K are converted to the active form in the liver as well. Liver is the major place for detoxification. Okay, so detox of your blood is happening here. So there are two phases of detoxification. You will talk about it in biochem. I don't remember which one this semester or next semester, but you will talk like details, how exactly does your liver degrade drugs and toxins. For now, just like an overview, we have phase one, which is oxidation. Here we use a very important substance which is called cytochrome P450. Okay, so that's like an enzyme which kind of hydroxylates and carboxylates your toxin or drug. It just adds these two groups to the toxin that you're trying to get rid of it, right? So this is the phase one, oxidation. Now, phase two is conjugation. You're adding glucuronic acid or glycine or taurine. These are the amino acids, right? You're adding these three substances, one of them, to the toxin that you're trying to get rid of. By adding one of these substances, you're making your product more water soluble. If it is more water soluble, kidney will remove it like this. It can easily diffuse through the filtration slits and your kidney will just get rid of it. So liver has very important job for that, right? So phase one, oxidation, phase two, conjugation. Through these two phases, you're getting rid of the drugs and toxins. And now this is the most important slide. Like, I cannot stress how important the slide is. Because your liver has so many different functions. Don't forget the other function, which I forgot to add here, is production of bile. It's an exocrine gland. It also makes bile, right? Because your liver has so many functions, you cannot expect that the arrangement will be the same for all the functions, right? That all hepatocytes make the same thing. Of course, they're very important cells, but they're not like super cells. Okay, so still the arrangement will be different depending on the function. So if your function is to make bile, the hepatocytes will be arranged in this manner. If the function is to simply filter the blood, then the arrangement will be in this manner. So we need to learn the arrangement, right? Here is the structural component of your liver. That's what it consists of. That's what liver is consistent of. The most important thing is parenchyme, right? The functional property, the functional unit of your liver is hepatocyte. And the arrangement of hepatocytes will be different, we will see, depending on the function. Of course, stroma, that's a bunch of connective tissue. This tissue is continuous with a capsule. Your liver has a capsule. This capsule is called glissons. There's only one area on the liver which has no capsule. They call it bare or naked, bare area of the liver. And that's part of the liver which is in direct contact with the diaphragm. So in your cadaver, you will see the diaphragm is touching a part of the liver. And if you lift the diaphragm just a bit, you will see that it's not shiny. The liver there is not shiny because it doesn't have a capsule there. The glissons capsule is not present there. So that area is called bare area of the liver. Sinusoids, you remember which kind of capillary are these?
Discontinuous.
Discontinuous. So liver, bone marrow, and spleen are the areas where your capillaries are discontinuous, so you could filter better, right? So this is the sinusoids are going to be here. And outside of your sinusoids, you have perisinusoidal spaces. These spaces are called spaces of Diese. We'll talk about them in a sec as well. Okay, so this is general structural components of your liver. The three ways to describe the function of the liver is by introducing something which we call lobule. So your liver will consist of three functional lobules. What is the shape of a classical lobule? It is a hexagonal shape. What is the shape of the portal lobule? It is triangular. What is the shape of the liver acinus or liver lobule? Here it's not looking how it should. It is diamond shape. Okay, diamond shape. So these are the three different lobules, and these lobules will have different functions. So first of all, in the center of your hexagonal lobule, you have a vein. This is called central vein. In the periphery, where the dots are, you have portal triads here. Okay, so these dots, they have portal triad. What is portal triad? This is your hepatic artery, portal vein, and a bile duct. So in each of this dot, you must see a branch to any of these structures. So I repeat, here you should have portal triad. Portal triad consists of the hepatic artery, portal vein, and a bile duct. So let's begin with the classic lobule, right? So what does our classic lobule consist of? So how do you call a vessel in the center? You call it?
Central vein.
Central vein. The classic lobule has hexagonal shape, right? So if we draw it, so this is how it's going to look like. So it has hexagonal shape. In the center, there is the central vein, the structure. What do you have in the periphery? What are here?
Portal triad.
Portal triad. You can see them here very nicely. They have shown it for you. So this will be what?
Portal triad.
Particular.
Hepatic.
Hepatic artery. So this one is the hepatic artery. What about this one? Portal vein. Okay, so here we have portal vein, and the green one is the bile duct, right? So the green one is going to be the bile duct. What about these structures? What are they? These are hepatocytes. Okay, so these little tiny cells here, they are hepatocytes. And in the classic lobule, you can see that the arrangement of hepatocytes, it is only one cell thick, but it is a column of hepatocytes. There are many layers that are going down, but the thickness is still only one cell thick. What is between your hepatocytes? So we have like one column of hepatocytes here, we have another column of hepatocytes here, right? But what is between the hepatocytes? Between the hepatocytes, we have sinusoids. So right here, for example, this vessel right here, this is your sinusoid. But take a look on this picture. What do you see? Do you see that the hepatic artery and the portal vein are draining into the same vessel? They're draining into the same sinusoid. So a question for you. Do hepatocytes ever get exposed to pure blood, to the non-mixed blood? Do they ever get exposed to the non-mixed blood?
No.
Never, because you can see that these sinusoids are occupying majority of the area which is right next to the hepatocytes. And these sinusoids carry mixed blood. What do I mean by mixed blood? Because you can see that there are two vessels draining into this area. What are these two vessels? Hepatic artery and portal vein. Remind me, where is the blood from the portal vein coming from? Where is the blood of the portal vein coming from?
From the
Intestine.
liver to the
From intestines. It's coming from the intestines. The blood which is carried by the portal vein, it's going into the liver, and it is carried from the intestines to the liver. Where is the blood from the hepatic artery coming from? It's coming from aorta, from one of the branches of the celiac trunk, okay, which is coming from aorta. So agree with me that the blood by the artery, hepatic artery, it's an amazing blood. It's oxygenated here. There's lots of oxygen. But what is the significance of the blood from the portal vein? What is it rich in?
Glucose. Or minerals.
Nutrients, just simply nutrients, glucose, vitamins, whatever you have eaten. But now I have a question for you. Is there anything else that the portal blood is rich in? Don't forget it's coming from intestines.
Lipids.
Toxins. Your intestines do not care. They absorb whatever they can, including pathogens, including something which is not meant for your body. What did we say the job of the liver is? Detoxification. Its job is to remove the toxins and send this amazing blood to the rest of the body. So do you understand why are we mixing the blood here? Why are we mixing the blood in the sinusoid? Arterial blood carries oxygen-rich blood. The portal blood carries nutrients-rich blood. All your hepatocytes have to do is to remove the toxins, and then this blood is amazing. It's rich in oxygen and nutrients, and send it to the rest of your body. So do you understand what is the purpose of these sinusoids, right? So they are the mixing area specifically so your hepatocytes could detoxify the blood that is coming from the portal circulation, and so they could add oxygen to this nutrient-rich blood. So they could send this amazing toxin-free blood all the way to the rest of your body. So here we have our sinusoids. We have said these are the discontinuous capillaries, our sinusoids. Which vessel is here?
central.
Central vein. Central vein is which kind of vessel then? If it is right after your sinusoids, which kind of vessel is it?
Presence.
Discontinuous.
Discontinuous are here. Your sinusoids are discontinuous and they're emptying into the central vein. But is it technically a vein?
A venue?
A venule. Which kind of venule?
Hepatic.
Which venule is after the capillary, guys? Come on. Post capillary venule. So central vein is not really a vein, and this is very important. Its name, we call it central vein, but which kind of vessel is it? Okay, so this vessel is going to be the post-capillary venule. So central vein is post-capillary venule because which kind of vessel is emptying into it? That's your discontinuous capillaries, right? So your sinusoids are emptying into this area. Is it clear?
Yeah.
Yes, okay. Now, there is something which is called space of mole. And space of mole is going to be this space right here. Okay, so the space right here. So space of mole, it's kind of at the edges of your portal canal. It is between the hepatocytes and this connective tissue, which is outside. Okay, so the space of mole is going to be right here. Guys, just a sec, the children came. Let me just quickly close the door. Okay, so space of mole, I repeat, is just this area right here. It's just like a space, which is basically located kind of between your portal triad and the first hepatocytes which are facing it. Okay, so we call it space of mole. So this space right here. Okay, now for the portal lobule. So how would you call this structure?
Portal triad.
Portal triads are here, here,
Class,
here are the
classic,
portal triads. How would you call this?
This.
classical lobule.
Classical lobule. Okay, so this is your classic lobule right here. Okay, so this structure is the classic lobule right here. Pooja, I'm going to mute you because you're giving me echo. Yeah, thank you so much. Okay, so yeah, so this is going to be the classic lobule. Okay, so this structure here, this is the classic lobule. The portal lobule is not hexagonal. As you can see, it has a triangular appearance. So this is your portal lobule right here. So what was in the center of classic lobule?
Central vein.
Central vein. What is in the center of portal lobule?
Central vein.
The triad.
This
This
the
is the
center?
triad.
Portal triad. Okay, so you're going to see that in the center of the portal lobule is the portal triad. So as you can see, it changed now. Because portal triad is in the center, it has to be exocrine function. Because what are we trying to do? We're trying to collect bile. And if blood flows towards the central vein, how will the bile flow? It will go the opposite, right? The hepatocytes will make the bile, and this bile will flow towards your bile duct. It goes in the opposite direction of the blood. So remember it. So I forgot how they called it. They say the blood flows centrifugally or something like this, right? So it flows towards or towards the center. There's this particular word they used in the self-control test. We will see it in the past paper. But basically the idea is that the blood flow and the bile flow are in the opposite directions. They're going in the opposite direction. The blood goes from the portal triad to the central vein. In other words, from the periphery to the center. The bile goes in the opposite direction. So here I have some hepatocytes along this way, and these hepatocytes are making bile, and this bile is going towards the portal triad. It's going towards the bile duct, which will be collecting this bile, right? So it will be collecting this bile. So this is why the center is different, right? So just remember that in the portal lobule, triangular function, triangular structure, and it has in the center the portal, portal triad, right? In the periphery, it has the central veins. And now we come for the liver acinus. So again, here you see hexagonally shaped lobule, right? This is a classic lobule. If it was like this, for example, right? So then it would have been the portal lobule, because what is in the center? The portal triad with the bile duct. Liver acinus has something to do with the blood perfusion. So which area will be perfused first? So you can see that this is the area of your liver acinus. It is lozenge or diamond shape. It's the same thing, okay? So diamond shape structure. This diamond shape acinus is divided into 3 zones. There's the zone number 1, zone number 2, zone number 3. Which zone is closest to the central vein? 3. Which zone is closest to the portal triad? 1. So now we have to talk about these 3 different zones. And tell me, which zone is the first one to receive nutrients?
3.
1.
1. Why 1? Because here we have portal triads. Inside of the portal triad is the hepatic artery. And this hepatic artery carries very nice oxygenated blood. Right next to it, there is the portal vein, which carries nutrients. So what is the first zone to receive all of this nice blood. This is the first zone. Which zone is the first to die from ischemia?
3.
3.
Because it is the furthest away from the blood vessel. So if you cut off the blood supply, the first zone to die will be third, because it is the furthest away from the blood, right? So it's the furthest, so it will be already missing the blood. So, but if you cut off the blood, which zone is the first to die after the exposure to the deadly toxin?
1.
1, because it is the closest to the blood. So deadly toxin comes from the blood. So yeah, I'm the first one to encounter it, so I'm gonna die first. So these kinds of questions you have to kind of understand. So zone number 3 in general is safe from toxins, right? Because it is the furthest away from blood vessel. But because it is the furthest away from blood vessel, it is very prone to dying first from ischemia if you cut off the blood supply completely, right? Zone 1 is very lucky because it gets everything first. It gets the nutrients first, oxygen first, but also toxins. So if there is some kind of toxin, right, the zone 1 will die first. Is it clear?
Yeah.
Okay. There was a question I'm trying to remember, just a second. Each classical lobule contains how many halves of the liver acinus? I repeat, each classical lobule contains how many halves of liver acinus?
6.
6.
Very good. So we just count. This is a half, right? So 1, 2, 3, 4, right? 5 and 6. So there should be here 6. Okay. Blood supply to the liver. We talked about it. So it has a dual blood supply, right? So the hepatic artery carries oxygenating blood. The portal vein comes from the digestive tract, so it carries not only the nutrients, it also carries the toxic stuff from the intestine as well. So you can see majority of the blood comes from the portal vein. Majority of the blood in the liver is from the portal vein, 75%. 25% is from the hepatic, right? Okay, now there is something called Kupffer cells. Kupffer cells are in the sinusoids. Okay, so they are macrophages. So macrophages of the liver, we call them Kupffer cells. So take a look how the way we are here, right? So these are 1 cell thick hepatocytes, but as you can see, it is a column, right? It goes down like this. Between hepatocytes, you can see sinusoids and occasionally bile ducts. How is the blood here in the sinusoid? Is it going towards the central vein or away?
Towards the central vein.
Towards. So blood in the sinusoid is going towards the central vein. Blood in the sinusoid is mixed, right? Because 2 vessels are entering it. Not only the portal vein, but also the, not portal, hepatic arteriole, right? So hepatic arteriole will be entering there as well. What about the bile duct? How's the flow? Is it towards the central vein or away? Away from the central vein, but towards the bile duct, which will be collecting all of this bile, right? So Kupffer cells are inside of the sinusoid. They're inside of your sinusoids. They're macrophages. Now, there's something called perisinusoidal space of Diese. Okay, so here we have our hepatocytes, right? We can see it here. And this is a sinusoid right next to it. You can see that Kupffer cell is a macrophage, which is just sitting in the sinusoid. But the space, which is between your sinusoid and hepatocyte, the space is called space of Diese. So if we take a look here, this is our space of Diese, right? So between the hepatocytes and the sinusoid, this is going to be known as the space of Diese. Space of Diese is quite important because here we have a cell which is called stellate cell, or another name for it, it is also known as the Ito cell. Ito cell has a mesenchymal origin, so it is a pluripotential stem cell in a way, but this is the major storage of vitamin A. So Ito cell, which is sitting in the space of Diese, is going to be just sitting there and collecting your vitamin A. In pathological conditions, for example, liver cirrhosis due to alcoholism, because it is a pluripotential cell, Ito cell changes. If you have an alcoholic, Ito cell changes. It's no longer storing vitamin A. Instead, it differentiates into myofibroblasts and it starts to deposit more collagen fibers. So in a way, your Ito cell is responsible for the liver cirrhosis as it is. As you know, liver cirrhosis is scarring of the liver tissue, right? We just add lots and lots of collagen fibers. So the cell which is responsible for this, in a way, is your Ito cell. Is it clear?
Yes.
Okay, hepatocytes, okay, about 20 to 30 micrometers, polygonal in shape, very important. They are multinucleated. So it's very typical to see a couple of nuclei in a cell. Okay, so here, for example, you have a cell with 3 nuclei, right, with 2 nuclei. So it's very, very typical to see a bunch of nuclei in the hepatocytes because they have so many functions. Okay, so one nucleus is not enough, so you need lots and lots of nuclei. Lifespan is about 5 months. Cytoplasm is very acidophilic because of peroxisomes. Okay, that's the reason for that. Peroxisomes, as you remember, are very important in detoxification. They contain peroxidase enzymes, right? Like hydrogen peroxidase. So you're using these enzymes in order to convert in order to break down the toxins. Lymphatic pathway, okay, so quite important. You remember space of mole?
Mm-hmm.
It was where?
Between the
Between the first hepatocyte.
So between the first hepatocytes and the capsule, right, where the portal triad was. So here we have a space of mole. You can think of space of mole as this bucket, which is just collecting lymph. So lymph will also be flowing the opposite direction, the same as bile, right? So lymph also goes in the opposite direction. So space of mole is just like a bucket, which is just kind of, I don't know, collecting all of this lymph, and then lymphatic vessel will be formed there, and then this lymphatic vessel will go down, right? It will exit your liver. Okay, so the same direction as the bile. And now we come to the super important part, which is the biliary tree. So from where to how. So let's draw our hepatocytes. So we have said that hepatocytes are polygonal in shape, right? But it's very important that they're 6-sided hepatocytes as well. So in a way, when we say that hepatocyte is polygonal, would be much better said that they're hexagonal as well. So your classical lobule is hexagonal. And which cells do we have here? Here we have hepatocytes. And what is their shape? Also hexagonal. Everything is hexagonal, very convenient. So there is one hepatocyte here. Again, guys, this is not a lobule. This is a hepatocyte in the lobule. Okay, this is another hepatocyte right next to it as well, right? And this is another hepatocyte right next to it as well. What is right next to your hepatocytes? What is here?
The sinusoids.
Very good. So here we have the sinusoids, and how do you call a space between the sinusoid and the hepatocyte?
Space of Diese or something.
Space of Diese. Very good. Okay, so this area right here, this is known as the space of Diese. Which cell is sitting in the space of Diese?
the
Itocell.
stellate.
Okay, so itocell will be sitting in the space of Dieze. What is the job for the itocell?
Storage of vitamin A.
Storage of vitamin A. Which cell is sitting in the sinusoid? A macrophage, which we call Kupfer cell. In the sinusoid, there is a Kupfer cell. So is it more understandable, more or less, where we are, right? So hepatocytes, blood vessels, we're in the lobule somewhere. So how do we start making bile? Where do we put the bile? We put the bile at first into the bile canaliculi. Bile canaliculi are the first vessels where we put the bile into. And it's very important that they make a complete loop around 4 sides of the 6-sided hepatocyte. So for example, okay, we do something like this. Okay, so the bile canaliculi are going to be on these sides. I know it says around 4 sides, typically it's 3. So these are your bile canaliculi. They're just outside of your hepatocytes, right? So these ones right here, they're bile canaliculi. So your hepatocytes, what do? They just add bile into these bile canaliculi. There you go, centrifugal. It's the opposite. So centrifugal is when you go away from the center, right? So when you're spinning something, it goes away from the center. So bile flow is centrifugal. It's going away from the central vein. It's going to the bile duct. A bunch of bile canaliculi are going to join and form intrahepatic ductule, which is called canal of Herring. Okay, so imagine there's another bile ductule here, right? And they're going to eventually fuse, and this fused bile duct is intrahepatic. It's in the liver. It's not in the portal triad yet. It's in the liver. So we call it intrahepatic ductule or canal of Herring. These canals of Herrings are going to carry the lymph to the interlobular bile ducts. Where are the interlobular bile ducts? Well, they're right here. Okay, so the bile ducts which are in the portal triad, you call them interlobular because this is one lobule, there is another lobule, so they're right between the lobules, right? So these are the interlobular bile ducts. These interlobular bile ducts are going to kind of fuse together eventually and form a right and left hepatic duct, which will eventually fuse as well and form common hepatic duct. So let's do the pathway again. So if here I have my hepatocytes, on the sides of my hepatocytes, I have the first vessel, which is bile canaliculus. Bile canaliculi, many of them fuse together. And as they fuse together, they form intrahepatic ductule, which is called canal of Herring. Canal of Herring opens up into the interlobular bile duct. Where is interlobular bile duct? Where the portal triad is. So the bile duct in this triad is called interlobular bile duct. From here, you go to the right and left hepatic duct, and from there, you go to the common bile duct. Okay, everyone looks so confused. Okay, guys, you will watch this video. Just watch it again. Liver is a huge topic, okay? So it's very difficult. I understand, just watch it again. So you will see it. At first, it's a lot, but then when you watch it again, you will understand what I'm talking about. Okay. Ducts of Luschka, we have talked about them. You remember? These are the embryological bile ducts in the gallbladder, right? They're remnants of the embryonic bile duct. Adult human liver is making about 1 liter of bile a day. We have pig liver slides because human liver does not look like this. In human liver, we don't have this connective tissue septa, so the lobules are not visible. You cannot see the lobules very clearly, okay? So majority of the time we see the pig liver slide. Okay, so at first when you look at it, which kind of lobule is this? Classic. This is a classic lobule, more or less hexagonal shape, more or less, but okay. What is in the center?
Central vein.
Central vein. Which kind of vessel is central vein? Postcapillary venue. It's very important. It's not a vein, it's a postcapillary venue. At the edges, you can see these structures. What are they?
Portal
triad.
Portal triads. If in the oral you say portal triads and they're like, just probably they want portal canals with the portal triads, right? So it's still a space, it is still a canal inside of which you can see portal triad. And how do you call these little things?
Hepatocytes.
Hepatocytes. Okay, so these are your hepatocytes. And you can see that there are white spaces between hepatocytes. So what could those be?
Sinusoids.
Yes, these are sinusoids, right? So these are the discontinuous capillaries. So whatever is reddish, eosinophilic, that's your hepatocytes. Whatever is kind of pale, these are sinusoids. So we magnify into the portal canal, which contains portal triad. And here I have already named it for you, so you can study, so you can kind of see it for yourself. So first, how do I go? Very easy to identify a ductule. First of all, it's not a duct. All of them are very tiny, so it cannot be a duct. It has to be a ductule. You remember that they look weird. They have simple cuboidal epithelium, and there is no red blood cells inside. So I think it's very easy to at first identify the bile ductule if it is small, or bile duct if it is big. Once you identify the bile ductule, for me personally, the next, which is very easy, is the arterioles or arteries, because they have a circular shape and the wall is thick, right? There's additional layers there present, so it's very easy to identify that. And then the last one, whatever is left, it has to be a venule, right? So portal circulation has to be a venule. Very kind of collapsed looking lumen, right? The wall is very thin, just endothelial cells, which we can see here. Your turn. What are these?
Bile ductule.
So these are bile ductules. I'll show you a duct. This is not a duct. They're so tiny. Look, hepatocytes are still visible, so it cannot be a duct. What about these ones?
Hepatic arterioles.
Hepatic arterioles. Okay, each and one of these, this is the hepatic arterioles. And then here, this is
Portal vein.
Portal vein. Okay, so it's a vein. It's a bit too big, right? So it's quite huge. So it's like maybe like a small vein, right? So this is the branch of the portal vein. Again, which cells are these? Hepatocytes, and the whitish area between them is the sinusoid. Okay, so again, this is a central vein. If it was a vein, you would see it as a vein. Here, we just see endothelial cells only, right? Endothelial cells only. So it must be postcapillary venule, because postcapillary venule and capillaries, they have a very similar arrangement. So this is a central vein, that's its name, but the type of vessel it is a postcapillary venule. Here you see hepatocytes, there are stacks of hepatocytes, right? And between them, there are sinusoids. You can see that there's some kind of stellate shape cells in the sinusoid. So if we magnify, so this is what we can see, right? So these are hepatocytes, and you can see there are spaces between them. These are sinusoids. And you can see that within the sinusoids, there are stellate shape cells. These are your Kupffer cells. These are your macrophages. Remember, they're within the sinusoid, right? So these are your Kupffer cells, or the sinusoidal macrophages. Now, where are you? Are you in the portal canal? No, you can see you're a bit outside. yet the cells look very much like the cells which we see here, right? For example, this one and this one. The cells are identical. Take a look at these cells and take a look at these cells. They look identical. So this is a bile ductule of some sort. But this bile ductule is outside of your portal canal. It's not in it, it's outside. It's in the liver. It's within the parenchyma of the liver. So how do we call this bile ductule? We call it intrahepatic bile ductule or canal of Herring. You remember? Do I need to go back? Yes or no?
Yes.
Okay, so we're going back. There you go. Canals of Herrings. You remember that lots and lots of little tiny bile canaliculi, they have fused together and they have given you the intrahepatic bile ductule, which is in the liver. It's intrahepatic. We call it canal of Herring. This canal of Herring will eventually lead you to the interlobular bile ducts, which are here, which is in the portal canal itself, right? So this one that you can see here, it's not much, but that's how it looks like, okay? So this is your canal of Herring. It's like bile duct cells, which are located in the parenchyma of the liver itself, right? Okay, liver pig azan. So what is the purpose? Of course, to show you some collagen fibers and etc. So this is your portal canal, right, which is like at the border, but we're looking at this one, okay? So we're looking at this huge ass structure. So this is like one of the bigger ones, like huge portal canal. So here you can see something with columnar epithelium, right? So it cannot be a vessel of some sort. It has to be a bile duct. So this is a bile duct. As soon as you see that epithelium is cuboidal, columnar, it must be considered duct. If epithelium is cuboidal, it is still a ductule. Okay, it's still a bit tiny. So this is a huge ass bile duct. What about these ones?
Hepatic arterial.
Very good. These are the hepatic arterioles. These structures right next to it are nerves. So we can see that their nerve fibers are present here as well. Okay, what about these ones?
Nerves.
These ones?
Portal vein.
Portal vein. It's a vein. Okay, so this is portal vein. This is also portal veins. These ones?
Nerves.
Nerve fibers. This one?
Arterial.
Arterial? No. This is arterial. Okay, arterial is this one. Okay, these little tiny structures, they are arterioles. This one, look at the muscle layer.
An artery.
Artery. This is hepatic artery. It's the artery. It's huge artery. What about this one?
Duct.
Bile duct. Because epithelium is columnar, so it is bile duct. So these ones are on the bigger side. It's like the main vessels which will be giving you these branches that we see. Rat liver, trypan blue, nuclear fast. We already saw this dye last semester. This dye is specifically for the phagocytotic cells. So if you have any phagocytotic cells, they will ingest this trypan blue, and the non-phagocytotic cells will simply be stained with nuclear fast. So everything which is in blue color, this is what? Liver macrophage or Kupffer cell, right? So this is the Kupffer cell. What about this one?
Cytocells.
Central vein. Okay, so this is the central vein. And this is your human liver. Do you see any lobules?
No, not really.
So we magnify. Is this the lobule? I don't know. Is this the central vein? Is this the portal thread? It's very difficult to see it. So human liver as you can see, it does not have this much of the connective tissue septa, right? Okay, so second self-control test is done.
Sorry.